Okay, we're ready. Okay. Hello, everybody. We are really happy to have you all here. This is a day that it was very hard to be organized, and all the hard work has been done from Dr. Andreu. So he is the man that I would like to make the housekeeping and start the works of these sessions. Thank you.
Dear esteemed colleagues, on behalf of the Second Department of Urology in Interbalkan Medical Center, I have the honor to chair a great meeting about the Exelixis in prostate enucleation. The initial idea was to organize for the first time in Greece a masterclass with almost every endoscopic technique of prostate enucleation. Our project was reviewed and endorsed by the scientific committee of the SIU, Société Internationale d'Urologie, which is so important for us. During recent years, prostate surgical treatments, especially in benign hyperplasia, have changed and evolved a lot. This is because the ex-gold standard, the historical TURP, had its proper limitations, especially concerning prostate volume, but also problems and complications such as bleeding, TURP syndrome, relapse. Surgical techniques, but also our tools have evolved in a considerable way, and today we have lasers such as holmium, thulium fiber, and KTP laser. At the same time, pioneers in this domain, and we have many of them present in this room, Professor Gravas, Dr. Gomez Sancha, Dr. Meneghini, he's arriving, Dr. Roche, Dr. Misrai, Professor Soudoulidis, and finally my associate, Dr. Bekos, helped with their gnosis and their dexterities to make these techniques suitable for everyone by fine-tuning them and spreading their knowledge to everybody willing to learn. We had Exelixis from the three-lobe technique to en bloc enucleation and early sphincter release that transformed the results after this kind of operations. They also contributed to the democratization of these complex-to-learn techniques and made them easier to adopt from any urologist interested to develop in this field. Our team took this important decision 3 years ago to get trained and develop in HOLEP. We expertise in minimal invasive techniques and robotics, but I have to admit that we were a bit hesitant to change our habits like bipolar TURP tourists. We started with videos of HOLEP before a mentorship with my ex-professor during my residency in Rennes, in France, Professor Sibert Louis, that I thank a lot. He is the director of this formidable training center, the MTC in Rennes, offering courses with simulators including all medical specialties. We traveled with Dr. Bekos afterwards to Germany to see Professor Knoll performing low-power HOLEP, which was finally our choice and the only way to be able to start this activity in Greece. HOLEP represents a big financial investment in new endoscopic material and lasers. We decided to proceed to an investment in low-power HOLEP of 50 watts that helped us start the new activity, and we equipped 2 hospitals here in Thessaloniki and in Athens. Professor Sibert helped us begin our activity in Thessaloniki, being present at the first session of 6 operations. After more than 200 cases, we visited our last mentor, Dr. Fernando Gomez Sancha, here present, well known about his didactic character, but also his ethos. He was willing to share all his tips and tricks, and the day after our return, we divided our operating time by half. The success story of our team with HOLEP that increased more than 300% our activity in BPH helped other institutions to make the step forward and buy these new lasers and invest in HOLEP. At least 6 new lasers in different hospitals were bought in Athens the last 2 years, and different teams started their adventure in HOLEP. The technique of enucleation was finally adopted from most of us, and a need of training was created for this demanding operation. This is a plan of training proposed from the French Urological Association, permitting to overpass the learning curve and achieve better results. We see that more than 100 HOLEP are probably needed to be able to be confident in any prostate volume. And here we are today. We are ready for a new investment in our clinic in a high-power laser and the creation of a training center. Our thesis is that gnosis must diffuse, and our role is to share our experiences and help others begin. This is the meaning of this meeting and the development of our training center in BPH with our partners, providing us with lasers and simulators. We have the chance to have among us the best in every technique for the prostate enucleation with different power sources. We hope that this meeting will help our colleagues decide which is the most suitable technique for them. And altogether, we will make progress that will benefit our patients. Every participant can have a try with our simulator, but also be present to a live case and have the chance to interact with the best of the field. I would like to thank everybody in this room for your presence, but also the virtual participants. They are more than 100, which is a great success for us. They are from all over the world, from countries like the USA, Brazil, Peru, Argentina, Guadeloupe, Mexico, Colombia, Belize, India, Yemen, United Arab Emirates, Saudi Arabia, Turkey, Singapore, Taiwan, Indonesia, Spain, Portugal, Italy, France, UK, Poland, Morocco, Serbia, and of course, Greece. It's crazy. It's the first time. It's really crazy. We're very happy for that. I also want to thank our sponsors, not only for their financial support, of course, but more about their collaboration at everyday life, supporting our job. Finally, and most important, I want to thank the direction of our hospital, the president, Mr. Apostolopoulos, Mrs. Ofidou, Mrs. Athanasiadou, Mr. Hatoupis, Mr. Sarandeas, Mrs. Katsigiani, Mrs. Argyropoulou, our anesthesiologist, my colleagues Thanasis and Christos, our secretaries, our nurses, Eleni and Victoria, Marios, and all the other members of the board of our medical group that believe in us and help us realize our professional dreams. Thank you very much.
Thank you, Dr. Andreou. We are all very excited to participate in this session. I would like to invite Professor Stavros Gavas to talk us about the AUA guidelines for BPO surgical treatment.
So first of all, thank you very much for the kind invitation. My dear friends, Thanasis and Andreas, it is a great pleasure for me to participate in this course, and I'm very confident that it will be a big success. So I was given the task to present on the EAU guidelines for the management of benign prostatic obstruction and what is the place of the prostate enucleation. I have no conflict of interest related to this presentation. So we live in the era of evidence-based medicine, and that means that if we want to offer high-quality healthcare to our patients, we need to have this healthcare consistent with the best available evidence. And the best available evidence comes from the analysis of systematic reviews and meta-analysis of randomized controlled trials, pooled data, and well-conducted randomized controlled trials. However, today I will not focus only on the guidelines, but also on the position of enucleation exactly in the era of evidence-based medicine. But as clinicians, what we need from the guidelines is to have some good recommendations. That means recommendations that will indicate to us what to do to which specific subpopulation of patients, under which specific circumstances, and this recommendation should use a clear language, not words like may or consider or think, no, a clear language. And this recommendation should be implementable, and so we should also be able to measure the impact of this recommendation in our daily practice. So when we develop recommendation and guideline, actually what we do is to evaluate the evidence. So we evaluate the quality of evidence, the benefit to harm ratio for our patients, the values and the preferences of the patients, and if it's possible, also the cost of the procedure. And when we take into account all this, then we can reach to a recommendation that is strong or weak, against or in favor of a specific treatment or a specific test. So if you look at this algorithm developed by the EAU Guidelines Panel on male ads, previously, in the past, the surgical section of the guidelines was based on technology rather than the surgical approach. But in our daily practice, in clinical reality, it's primarily reflected by surgical approach and not necessarily by a specific technology. For this reason, we changed the guidelines, so the invasive section now has 5 subsections: resection, enucleation, vaporization, alternative ablative techniques, and non-ablative techniques. And these are the recommendations of the EAU guidelines for the enucleative techniques. So pay attention to the wording, but also to the method that each one of these techniques is compared to. So if you look at the open prostatectomy, is indicated for men with big prostates in the absence of bipolar enucleation or HOLEP. If you look at the HOLEP, then we have a strong recommendation as an alternative of TURP and open prostatectomy. And for the bipolar endoscopic enucleation, we have a weak recommendation as an alternative to TURP. So for the diode laser, again, a weak recommendation as alternative to bipolar, to enucleation or TURP or the HOLEP. For the thulium young, we have a strong recommendation as an alternative of TURP and HOLEP. Why? Because this is what the studies indicate to us. The guidelines are based on the available studies. So we cannot have a big gap in our knowledge. We should always base our recommendation on the available guidelines. For this reason, we don't have recommendation for laparoscopic or robotic simple prostatectomy or for the green light laser enucleation, because we don't have randomized controlled trials that are needed in order to develop a recommendation. So why we need the enucleation? Obviously, we know from our daily practice that we have different subpopulation of patients. We have patients who are older and they have some severe comorbidities. Usually they are under antithrombotics, and this can result in a long waiting list and also in prolonged hospitalization. But also we have patients who are very fit, patients who want to have some durable results, and patients who are very much interested in preserving their ejaculation. And also we have patients with different characteristics, patients with big prostates, with small prostates, with different baseline characteristics. So always the eternal question is how much tissue we should resect. Should we completely remove the adenoma, or a minimal TURP or a channel TURP is more than enough, and we have the extra bonus of the reduced morbidity? The problem is that we have some conflicting results from the short-term studies. But if you look at the long-term results, we know that the more tissue we resect, the more durable results we have. And we know that very well from the historic series of open prostatectomy. And also, as Andreas mentioned before, TURP has some severe limitations. For example, the upper limit is between 80 to 100 cc's. I know. It depends on the experience and the expertise of the surgeon. Correct. But when we talk about the average urologist, the average speed of resection is around 0.6 to 0.7 grams per minute. And that means that if we have to resect a big prostate, then we need to prolong our anesthesia time and our operation time. And then maybe we have a higher incidence of TUR syndrome. I know. In bipolar TURP era, we don't have TUR syndromes. But again, there is always the risk of fluid absorption for our patients. This is a very interesting study coming from Germany with more than 10,000 patients. And this study shows that the larger the prostate, the higher the incidence of complication when we perform a TURP. This is another interesting concept. We know that all the different surgical procedures for the management of benign prostatic obstruction have a different impact on PSA drop after the surgery. But we know very well that the enucleative techniques, open and endoscopic, have the most drastic PSA drop. And we can use this PSA nadir as a proxy to evaluate the relief from the bladder outlet obstruction, because it is associated with a higher reduction in IAPSS and a higher increase in Qmax. And something that sometimes we disregard when we talk about with our patients, that more than 50% of our patients they are still under treatment with drugs after a surgical procedure. But from the available surgical therapies, the laser enucleation of the prostate seems to have the highest rate of medication discontinuation after surgery. What about sexual function? Now we have long-term data. So we have data from at least 5 years, and you can see there is no significant difference in erectile function between the surgical interventions and TURP in terms of de novo, erectile dysfunction, and the great ejaculation. And with all these new ejaculation preservation techniques, we can preserve the ejaculation in a significant number of our patients. Another big study coming from a large reimbursement database from Korea with almost 60,000 patients and a follow-up of 5 years. And what did they find? They found that the rate of reoperation was significantly higher in the TURP group compared with the HOLEP group. And in addition to that, patients who were treated with HOLEP had a lower percentage of need for drug treatment after the procedure. What about the patients who are receiving antiplatelets or anticoagulants? Again, I need to clarify from the very beginning that we cannot transfer directly the benefits of the laser vaporization to the laser enucleation. But again, the available studies show that the laser enucleation has better outcomes compared to TURP in terms of transfusion and bleeding. Again, there are some significant limitations because these studies were retrospective in their nature, and also they have a high heterogeneity. So we have patients with a prostatic volume between 50 and 100 cc's, and also there was a mixed population with respect to what kind of anticoagulants or antiplatters they received. Also, if they stop it, or they continue under treatment, or they had a bridging with low molecular weight heparin. So this was a rather provocative article we wrote in the past, and we tried to compare directly the different power sources in terms of functional results, incontinence, learning curves, subpopulation of patients who will benefit from different energy sources. And what we found, the conclusion was that there is no convincing data on the superiority of one energy source over the other at any endpoint. And the anatomical endoscopic enucleation of the prostate can be safely and effectively performed using any technology without compromising post-operative outcomes. This is a very interesting systematic review of the learning camps, and Vicent was part of this project. And I know that one of the main criticisms that the enucleation techniques have received is the rather steep learning curve. So this is a very nice systematic review that evaluated all the studies on the learning curve. Most of the studies are on HOLEP. So the learning curve for the HOLEP is between 30 to 50 cases. For the green light enucleation, there is a huge variation from 20 to 150 to 200 cases. And for the endoscopic bipolar enucleation, then you can see that you need rather 40 to 60 cases in order to achieve a level of experience or a level of competence. The main problem is the criteria we use to define this level of competence or level of experience. So our task is to find the most precise criteria to define this level of experience. And if we want to do so, I think that we need to adopt the trifecta or pentafecta. Trifecta includes combination of complete enucleation and morcellation within less than 90 minutes without any conversion to standard TURP. And pentafecta, we have two additional criteria: the absence of any postoperative complication and the absence of stress urinary incontinence at 3 months after the procedure in 4 consecutive patients. There are many patients There are many papers coming, and 1 year after 1 year, and you can see that indicate that enucleation is a size-independent method. And more on this, some colleagues moved one step further, and they now suggest HOLEP as a treatment for patients with a prostate smaller than 30 cc's. So, in conclusion, the academic consensus position the concept over the energy source. That means that it is the enucleation that makes the difference. Enucleation is enucleation, is enucleation, is enucleation, as Thomas Herman said. So the energy source has a secondary impact on the outcome of the enucleation, and it seems that it's more or less related to the institutional resources and the personal preferences of the skilled and experienced surgeon. And with respect to the guidelines do change because they depend on the available data. So if we have more studies, most probably the guidelines will change. The EU guidelines, I think, is the best guidelines we have because they do an annual search, they update the content, and they also reevaluate the strength of recommendation based on the new studies. They have, if you look at the algorithm, they have 3 decision points to assist us to select the right treatment. 1, if the patient can receive anesthesia. 1, if the second one, if the patient can stop the anticoagulants, and the third one is the prostate volume. But if you look very carefully at this algorithm, you can see that enucleation is almost everywhere in these boxes. So thank you very much for your attention.
Thank you very much, Professor Gravas. It was very important to see all these indications and be sure what we are doing. Do you have any questions, please?
So, no question for Professor Gravas. Thank you very much. It's always a pleasure to have you here and talk to us about these things. Basically, the guidelines is something that everybody has read, but it's always a privilege to hear about them from a guy that has actually write them. So, thank you for being here.
It's a good work. Thank you.
I would like to call Dr. Gomez Sanza for his presentation concerning HOLEP.
Thank you very much.
So, thank you for the invitation. I think Dr. Andreou is pushing very hard in Greece to move things forward, and I congratulate you for the effort and the drive to take the effort to organize such a meeting. And thank you, Dr. Bekos and Stavros, for everything as well. I'm going to start by, do I control the presentation or? Yeah. Okay. Why would we adopt anatomic enucleation of the prostate? We know that it does relieve bladder outlet obstruction better than TURP. Patients get much better symptomatically. We have reduced bleeding, shorter catheter time, shorter hospital time, superior catheter-free rates in patients in retention. It's highly effective in men with impaired bladder contractility. It's safe and effective irrespective of prostate size, durable, etc. So I think it is a no-brainer to adopt an enucleative technique if you're dealing with patients with BPH. But there are many challenges. When you do TURP and open prostatectomy in a department, it's very difficult to start. And I'm going to comment not only tips and tricks on how to do the operation itself, but also how to convince the hospital management, how to kick off your experience, how to learn safely, and then some other details that I think are interesting. Of course, if you want to convince the hospital management, you have to show them some of the studies that show the clinical benefit, but also the economical benefit. Purchasing a laser, purchasing the equipment can be expensive, but it pays off with time. Of course, you cannot approach the manager and ask him for money, because this is usually the response is going to be no. I think you have to imagine how your department activity is going to change if you start doing enucleation. So Most patients will go home before than 24 hours. You don't need ITU. You don't need to cross much blood before the operation. You'll have a lot of beds free for oncological procedures because the turnover is very fast. It's important to communicate this, because then when you make the numbers and when you realize that the degree of change that you're going to have, it starts looking like a little investment for a big benefit. Also, of course, it's important to budget for the learning costs. You need to budget for visiting another center, for learning, maybe bringing someone to help you when you start. Also, many people have this idea: if I do, I don't know, 2 TURPs every week, I cannot afford to buy a laser when you do your business plan. But of course, the moment you start doing HOLEP, you get more and more patients coming to you. So you have to have the confidence that the number of patients will grow and you will be able to pay for all this. And my advice is I think this is a surgery of maximums. You should have a very good camera, very good instruments, very good laser. So try to buy the best equipment you can. Also, for example, if you try to do HOLEP in your hospital and you're doing your first case, when you start doing this, there's going to be a lot of attention on you. And then the operation will take 3 hours. The anesthetist will tell you, you could have done 3 open in the same time, and then the manager will be discouraged. So I think it's very important to bring in someone who is very good at doing it, so you can show the procedure to the nurses, to the hospital management, to the anesthetists, and they will love it. And then, of course, when you do it for the first time, they will understand that you have to learn, but already they know how the treatment looks like. Also, how to learn safely. I think there's never been a better moment to learn. I think you have to have commitment. Everybody I know who does enucleation had the commitment to learn. They wanted to learn. Every reasonably apt surgeon can learn. It's not a surgery for expert surgeons or superheroes. It's something you can definitely learn. It's important to understand the procedure, because if you understand the procedure, it's actually quite easy to do. So the difficult thing is to understand the anatomy. We have never been there. When you do TURP, you have a lot of experience with endoscopic surgery of the prostate, but you don't know the anatomy. So there are many videos online. You can visit a center of excellence, and it's very nice when you do an arrangement, so someone will come to you not only once, but many times. So that's why I tell you, budget for paying someone to come, pay for his trips, make an arrangement so he can come, 6 months, once a month. So you can do the easy cases, he can do the difficult cases, and then you will succeed. It's also important that HOLEP is not a solo operation. You need nurses that can help you, who understand the morcellator, who can assist you properly in the operation. So you need to train your team and, of course, choose the easy cases. So when I started doing enucleation, I think the most unattractive aspect of enucleation was the risk of incontinence. There were many papers showing, 29%, 25%, 36% incontinent patients after 1 month, and this would take a long time to recover sometimes. And of course, it's interesting that these patients are incontinent, but then they seem to get better over time. So probably the way enucleation was being done, the sphincter was not irreparably damaged. And I worked with Tony Mundy years ago, and he would say that only God can make a sphincter. So, the thing is that over time we have understood more and more that the sphincter is a complex structure, and there are sphincteric fibers that go all the way to the mucosa. So the lesser sphincter has these circular and longitudinal smooth muscle fibers, but they go into the mucosa. So the mucosa is part of this mechanism. Also, we understand a little bit better the anatomy, how anteriorly the sphincter is more proximal and posteriorly it's more distal. And really, I think we have come to understand that when you do the classic detachment of the lobes without looking at the sphincter, you get this mucosal curtain. This is what I call the infamous mucosal curtain. And of course, if you think, where is this curtain coming from? Well, this is the mucosa that was already attached to the sphincter. So when you go with your endoscope and you dissect blindly in the apical area, you rip off the mucosa from the sphincter, and then, of course, the sphincter mechanism is damaged. Why do they recover continence? Probably because the mucosa grows back over time. So we came, it's been a long road, but we came to the realization that we need to protect the sphincter's mucosa to get good continence. So the challenge is enormous sometimes because we have a little hole, there's a sphincter, and from there we have to mobilize the adenoma and release it around without damaging the sphincter. So I think it's important to reflect about this. And when we started with green light enucleation, we used to do this initial scoring of the mucosa between the sphincter and the apex of the prostate, and we found out that the rates of incontinence we had were very low. So when you do this initial white line, I think what you're doing is you're protecting the mucosa and you're helping that at the end of the procedure you will have a sphincter that is covered by mucosa. So the technique, the way I do it now, is starts by scoring the mucosa, then localizing the posterior plane, developing the posterior plane, and then, of course, it's important to mobilize the apex. So it's not an immediate apical release, but it's more a progressive release that very carefully goes into the lateral plane, deepens the dissection a little bit towards the bladder neck. But before continuing towards 12 o'clock, you may have to make sure that you cut the attachments of the sphincter with the apex before continuing with the dissection. And it's incredibly useful to cut on the tissue. Sometimes we have to cut on the adenoma in order to get access to the plane. Some people think if you cut into the adenoma, you're going to leave tissue, but then this is an access incision that has allowed us to do this apical liberation very, very safely. So when you have to cut the 12 o'clock attachment, you see the apex progressively is mobilized, the apex descends, and then when you have to cut at 12 o'clock, you can initially cut carefully horizontally below the sphincter, and when you pass the landmark of the sphincter, then you can try to go up all the way to get all the adenoma out. One of the nice things of the en bloc operation is that the space that you are irrigating is very small. So if there's bleeding, you will wash it out very clearly. You know, when you do the classic incision technique, there's going to be bleeding from the mucosa, and this blood is going to go into the bladder, and then it's more difficult to wash it out. So working in this little space can be sometimes a little bit uncomfortable, but of course visibility is ideal. Also, as I have tried to depict here, the adenoma mobilizes with the movements, and it allows you to reach the bladder neck anteriorly and then posteriorly, and then, of course, send the adenoma in one piece towards the bladder. Tomorrow we will have more, hands-on experience on this. But the idea is that at the end of the procedure, instead of having this mucosal curtain and the deepithelialized sphincter, except at 12 o'clock, you have a completely epithelialized sphincter that will ensure that patients are continent. I think one of the problems, the lack of evidence with BPH procedures, is that following the patients prospectively is a pain. I don't know, you've made studies, and it's really difficult. You have to spend a lot of time, a lot of resources. So this is a prospective evaluation we did in 80 patients, and you can see the prostate volume. Prostate volume was about 86 grams, went down to 20 after the operation. The PSA went down to 0.6 after 3 months from 3.4. The flow rates increased very nicely, but the incidence of stress incontinence was pretty low, very similar to the preoperative stress incontinence rate or incontinence rate in this patient. So for us, it's now a rare occurrence. And we're not the only group that sees this. This is a Chinese group. They compared 3 different en bloc techniques, and they realized that their rate of incontinence postoperatively was very similar to what we got when they use a technique very similar to what I got, and you can see that even they copied my drawing. So it really works. It's important, like we have to discuss tips and tricks. Everybody asks me, what settings do you use? And I like to tell this story. I like drawing, and I'm not very good, but I watch all these artists who draw very beautifully, and everybody asks them, what pencil are you using? No, like if the pencil was going to make a difference. And laser settings are probably very important for stones, because more or less everybody uses the fiber in a similar fashion. And but with BPH, I think it's not only the laser settings, but of course the working distance you use. You know that the effect is going to be different depending on the distance. If you're too far from the tissue, there will be no effect. If you get closer, and this is with a classic holmium, you will get a mechanical effect that opens up the plane. Then you can have coagulation and mechanical effect, and then a disruptive or cutting effect. Now we have more complex pulse modulation settings that provide dissection and hemostasis. But of course, the working distance is important. Then, of course, as you can see, during the operation, the fiber moves around the adenoma. You can see the line. You have this MRI image in your mind. So these lines are quite easy to follow when you do an en-bloc technique. But of course, you can move faster or you can move more slowly. And that will also condition the amount of dissection you get, the amount of coagulation you get, the quality of hemostasis. So the surgeon is going to be responsible for this effect. And then, of course, to me, it's very important, where do you aim your laser? Because we are dissecting the plane. Initially, the prostate angles open up and then they close. You know, you go up and then you go down and then you go up. And then, of course, your aiming in relation to the line of dissection is going to be super paramount. So, for example, I recommend at the beginning of the operation, aim towards the line. But then if you want to, you know, take the curve, like the motorbike, the guy on the motorbike, you have to get closer to the adenoma. And that's because if you fire, you see, like below, you see, if you fire against the line of dissection, when the plane is changing the angle, you can easily get into the capsule. But if you fire a little bit closer to the adenoma, you will still dissect the plane, but you will not harm the capsule. Also, it's interesting when you do en-bloc enucleation, often you find adenomatous nodules. Sometimes these nodules grow into the capsule, and some surgeons just cut through them and leave the nodule there. But I am in favor of removing these nodules. I think in the spirit of HOLEP, we shouldn't be leaving nodules. Of course, probably they can condition a retreatment, but when you remove so much tissue, probably it's unlikely. But I have seen some cases, and I'd rather recommend to remove these nodules. Also, one of the advantages of the en-bloc technique is that you don't need even to go in the bladder before you start. I mean, you can start at the apex. So when I see a very big gland with a big middle lobe, I don't even enter the bladder at the beginning. I start my dissection. And in America, it's very typical that they do perineal urethrostomies, because when they don't reach the bladder properly, I had never had to do it because of the en-bloc technique. So normal scopes tend to reach. Probably patients with penile implants are an exception. And then many people tell you, you know, if you do en-bloc, it's going to be very difficult to flip the adenoma into the bladder. But of course, sometimes it is. But of course, if you rotate the adenoma carefully, so one of the lobes goes into the bladder, and then you follow the same direction to push the other adenoma, then you will be able to flip most of the adenomas. Otherwise, you can split it at the end, or you can do intracapsular morcellation. And of course, you will do perforations when you do HOLEP, but the idea is that you want to detect them early, and you don't want to do big perforations. So you have to control the way you use your energy, so the effect is soft, and you don't stay too long in the same spot, getting very deep, but you do a very smooth effect. And of course, you have to correct the plane so that you aim your laser inside the line of dissection a little bit or outside when you find the nodule, so you adapt to try to avoid the deep perforations that could be a concern. Regarding the UOs, I think it's important to visualize the UOs to avoid damaging them with the laser. I think with green light, probably the deeper coagulation of green light might be a little bit more problematic. And if I saw some obstructed ureters, and I heard about cases of obstructed ureters after green light damage. With holmium, I am a little bit less worried in the sense that holmium penetrate much less, and I think the tendency of these UOs to contract and obstruct is much less. So actually, if I do a partial lesion or I get very close, I usually don't do anything, just monitor the kidney of the patient, and most of the times, I think up to now, patients do well. Morcellation is another, challenging part of the operation at the beginning. It is a teamwork and it is safe, providing you stick to the rules of morcellation. And more or less, it's important to have it ready from the beginning of the procedure. You have to keep water flowing in. That's why you rely on other people to do that for you. And you should only morcellate if you have good visibility. Keep the mouth looking up and keep it in the midline. And of course, this dance, the drawing that I show you here, is that where you lower your hands so the tip of the morcellator goes up away from the bladder when you're going to activate the morcellation. And then a reflection in your learning curve. It is always safer to put a catheter and return another day. The patient will never be angry with you if you tell him, I had to stop because it was not safe to continue. He will be grateful. Maybe he doesn't like that. He will have another go, a second stage to finish the operation, but that is always better than having a big complication. So this is a nice thing that you have to have decided before the operation. So to finish, I think we live in a day where there are new technological advances, the new lasers, the thulium fiber, the hemostasis is amazing. There are differences between the lasers, but there are now many morcellators that are quite fast. The endoscopes are getting thinner, and the surgical technique has changed to make it easier to perform, and I think easier to learn as well. So just do it. And this is my talk. Thank you very much.
Thank you, Dr. Sanza, and thank you is not for your speech only, but for everything, because me and I believe many urologists are obliged to you for all the effort you have put to explain the technique, to train other people, and yes, thank you.
Thank you very much. Thank you. It's my pleasure.
So, do you have any questions?
Fernando, I have a question. What do you think about management of recurrence of mictional troubles, voiding troubles after the first enucleation of prostate? How do you manage it? Have you got? Do you want to go first to the medical treatment, or are you going back to the OR instantaneously? Are you doing the fibroscopy? What is the?
Well, I think in every post-operative, I try to simplify it to residents and younger colleagues. When you have a patient who had an operation, holmium, TURP, open, whatever, and he's not happy, you have to do an anatomical evaluation and you have to do a functional evaluation to understand what's going on. The anatomical evaluation can be a cystoscopy, for example. You can see if there's a stricture in the bladder, if there's a stricture in the bladder neck. These are not very common problems, but sometimes, of course, we see them. And then you have to have a functional evaluation. So I would do a urodynamic study to find out what's going on with the patient. I would say that with enucleation, the big majority of patients do well after maybe, you have secondary hematurias, you have small problems, retention, postoperatively, small problems in the postoperative moments, but most patients after 3-4 months tend to be really, really well, unless they have this kind of problem. I don't know, maybe there's a nodule, remaining that can behave obstructively. But I tend to think like that: anatomic evaluation and then functional evaluation to see what's going on. So another problem is the hyperactive bladders. Some patients, maybe 1 or 2%, they don't recover a normal bladder function after enucleation, and then you have to resort to Botox or something like that.
Actually, I was talking about
For the online
I was talking about the long-term recurrence, or perhaps 2, 3, 4, 5 years, or 10 years after enucleation. Have you done some remarks on that? What I see is that I would like to have your feeling about that. It seems that there is a capsule retraction after HOLEP or enucleation. And it seems that if you have a recurrence with prostatic nodules inside this retraction, you're gonna go to obstruction very quickly. I saw that medical treatment is not enough for these guys. And usually there is just a small recurrence, and when you go back to the laser and you treat them, sometimes with a small nodule, you have a very good result. And perhaps I would like to know.
Yes, that's why I insist that you should be very, very thorough trying to remove the nodules, because if you leave nodules, I remember when we did open prostatectomy, you would feel the fossa with your finger to see if there was an adenomeric nodule, remaining, because this could be a cause for recurrence. But yeah, this can happen, and of course, if there is a mechanical obstruction and the patient is obstructed, you have to go back and do it, which is probably easier. We see this with open prostatectomy. We see this with TURP. Of course, more often with TURP than other enucleative procedures. But this is the anatomic and then functional, and then you decide what to do.
Any more questions?
Okay, and just a comment in the previous questions, because we have people that are in new colleges, and maybe we would like to be more specific in our answer. I would like to say to the new colleges that when you have an urethral stricture, the problem is anatomical. When a patient has BPH, the problem is functional, not anatomical. It's not just an obstruction. If you have recurrence after enucleation of the symptoms because of the capsular retraction, this is anatomical, not functional, because this area is already denervated from the previous surgery. So, just my comment.
So, Fernando, thank you very much. Meeting you was really a pleasure and an honor several months ago.
It goes both ways.
And a really important moment of my professional life and personal life. So, just a question, because we know that in Greece, it's not a long time ago that we started doing HOLEP. What would you recommend to a young colleague that he wants to start? Because we know you're a pioneer. You did the apical release, early apical release, you did the M-block technique. But what I did for the first time was the 3-lobe technique. And I thought that it was much easier, but very time consuming. Do you think that we need to start from 3-lobe technique and then go to M-block?
No, I would recommend to start with M-block right away. What I do to teach my younger colleagues is to do the apical release myself first, and then let them complete the operation. So they get proficient and dissecting the plane, and then they start doing morcellation like that. And then as they get better in the second part of the operation, and then I let them do the apical release, because of course, when we teach this procedure, we don't want the patients to pay for it. And I think it's a safe model to learn M-block. I think M-block is probably easier than 3-lobe. 3-lobe is very confusing. So I push M-block, yeah.
Okay. And having a mentor, we cannot start just looking videos.
Definitely. I got a lot of messages from people who watch my videos, and one guy from the States told me he lost 10 kilos watching my videos because he would use the static bike, watching the videos for hours, and hours. But again, when he started doing en bloc, his surgical time went down, his rate of incontinence went down. So I think it's really something that needs to be pushed. The best way to learn is to go to a center where they do a lot and stay there for some time to really understand what's going on. You have to see the big prostate, the small prostate, the inflammatory, the good plane, the bad plane, the bloody prostate, and you have to see how this is handled. And then you understand and you're ready to face these complications yourself. The problem before was that the videos were highly selected. So you saw a video and you thought, this is amazing. And when you try to do it, it doesn't look the same. It's very confusing. So the more exposure you have to the procedure, the more you do. In Bulgaria, there's one guy, Dr. Georgiev. He doesn't know how to do a TURP, but he has been with me doing HOLEP, GreenLab, HOLEP for many years. Now he does an amazing HOLEP. He's super fast. He's an amazing HOLEP surgeon. He never did a TURP, and he learned en bloc, of course. So if you understand the procedure, you can do it even when you don't have a lot of endoscopic experience.
And just to add something small, we have also to convince your equipment that we are using to work at the specific time, because if you are inexperienced, usually the first thing that you have to deal with is that things are not working. So you need the experience to convince the laser to work. Usually it's the less problem, the video to work, and the modulator to work.
Yes, definitely.
Thank you,
Okay.
Fernando. You
Thank
give
you very much.
inspiration. Thank you very much. So we will pass to Dr. Jean-Baptiste Roche, a great friend of mine from our residency in France. So thank you for coming in Thessaloniki, and he will talk about thulium laser enucleation, TULEP.
Okay, so first, thank you. Thank you for your welcome. Thank you for your kindness. Thank you for all this friendship we have for years. And I'm very, very happy to be here. It's a real pleasure to discuss about surgical techniques. And I hope it's going to be okay. So I had the work to try to defend or to promote thulium surgery. So I will begin on that to try to describe this laser, to try to describe my way I use this laser and how I began with this laser, despite the fact that it was in an holmium wave at the beginning of enucleation. But I still think that there is a place for this laser, and so I would like to expose it to you. So first, I have to say that the first thulium I began with was a Exelixis in 2012. The first paper published was coming from Germany because it's a German laser from Lisa Laser. And the first result was pretty good with probably quite small prostate, but with excellent results in terms in PSS and voiding results, with reduction of catheterizing time and hospitalization stay when you compare it to TRP, with a number of urinary infection irritative symptoms. But it was a quite interesting technique, and the story of thulium began with the German guys. So I have to say that the wavelengths of the thulium is quite close to this one of the holmium. The energy is going into the water, so that's the reason why I think it's a quite safety laser, because there is no deep coagulation of the tissue, and so it's an interesting laser to work with. And as you can see on that slide, the diffusion of the energy is very superficial, and probably the most superficial of all the lasers on the market. It's just 1.2 millimeters. So interesting tool to work with. So thulium has laser specificities. It's possible to do enucleation, of course, and we're going to discuss and talk about that, but it's still possible to do vaporization, vaporesection, and vapoenucleation of the prostate with this laser. So these principles have been described by Torsten Bach from Hamburg. And so you can see that the vaporization is the destruction of the adenoma tissue. The vaporesection is the resection of small ships of tissue, and they began like that. And then after you can wash the different ships of prostate to remove this tissue. And then, and it was before any morcellation system. The vapoenucleation is the way to go to enucleation, with a combination with the vaporization of the median lobe and the lateral lobes, using at the end the morcellator, and then after, of course, the thulium enucleation with the blunt enucleation with laser support. So just a word of vaporization. It's a good technique, especially for patients who have small prostate and prostates with anticoagulation drugs. It's quite nice to have this technique, and I will show a small movie on that, because you can use it without any morcellator, and it's totally possible to use it with patients with anticoagulation drugs, and I sometimes still use it, because if you have an old patient with a small prostate and it's difficult to stop anticoagulation drugs, you can perfectly do this vaporization, and it's not mandatory to have a morcellator to use it, only a cystoscope or a resectoscope and the laser. So I have to admit that I began with that, because at the beginning I was doing some green light. I moved to the thulium, and I will tell you why. And I began with that technique because I had no morcellator. It was too expensive for the institution. And so we began like that with quite smart results, even if probably we have irritative symptoms more than with blunt enucleation during this procedure. So as you can see, and I want you to show this, the charring of the thulium. So it was the first generation of thulium we used to vaporization up to 200 watts. And if it's charring, it's nice because it's very good hemostasis. And you have to know that with the thulium, when you use it in a continuous wave and continuous emission, you have a very interesting hemostasis. And generally, the patient like this is one-day surgery. And so it's very cost effective, and you can use it with reusable fibers. And so it's possible to do 20 cases with that time. And I use it for my learning curve because it was interesting to use it very safely and have the first steps to manage the resectoscope, as you can see, because the movement of the surgeons with the hands are very different when you use a laser, when you compare it to TURP. And it was sometimes I used to make the learning curve easier. So as you can see, you can cut the different lobes, and then you can use vaporization of the tissue with a quite good anatomical results and absolutely almost no bleeding. So that's the first technique you can use with a thulium laser. So the second technique, the second technique is the vaporization of prostate. So it was my second initial experience with the thulium laser. It involves the resection of piece of prostate, and it's not mandatory to be in the plane. And you can switch from this experience not to be in the plane to try to find the good plane, the perfect plane of enucleation, but it's not very easy at the beginning. And that's the reason why I think for beginner with the thulium, it's an excellent technique for small and mild prostate to begin your laser experience. Of course, you have to limit, of course, you have to limit the size of the prostate you're going to treat. But with that, and with an initial experience of the morcellator with small volumes of morcellation, it's quite nice to begin, because the beginning of enucleation can be quite difficult, as we discussed before. So you will see it's when you use vapor enucleation technique, generally you use a 4-lobe or 2-lobe technique, because it's not mandatory to be in the plane. And then after, you're going to have an anatomic dissection of the prostate outside of the plane. And I have to say that I still use this technique when I have anticoagulation and when it's difficult to stop it, because I saw that the risk of scar drop after this kind of technique is probably reduced when I compare it to blunt enucleation. So like this, you go step by step from vaporization, and then to go to a technique approaching real enucleation of the prostate. So the problem in the technique, and that's the reason why the thulium was not very recommended at the beginning of enucleation, is that you have this charring. So as you can see, there is very good hemostasis, but it will be very difficult to find the correct plane of dissection when you use that kind of charring, because it's troubling the plane of enucleation. So as you can see, you manage the dissection, not in the plane, but going slowly, with time, with experience, with patience, in the correct plane. And with that, I have to say that there is no big mistake or big troubles with the patient during your first 50 initial case to have a good learning curve. And what is interesting with the thulium is that because it's a very superficial laser, you're gonna have, of course, irritative symptom because of the charring, but generally not more than 2 or 3 weeks, because it's very superficial. So the secretization is quite quick. So I think this is not a bad way to begin your experience with the thulium and to switch to enucleation. So what are the results of this technique? It has been published more than 10 years ago, and the results were quite good. So if you can see this trial, you see that of course the prostate volume was mined. It was 50 grams. The catheterization times was quite short. It was less than 24 hours medium, and the duration of hospitalization was generally 1 day. The PSA drop was not perfect, but it was reduced by 2. And if you see the results at 1 year, the Qmax was quite good, and the APSS was quite good too at 9 months. So interesting technique, quite easy technique to learn, and a good way to begin your experience with the thulium laser. And then after, we go to the enucleation of the prostate with the thulium. So I would like to discuss with you and expose the way I came from this vaporization to enucleation. So it began with Fernando with an amazing trip in Bulgaria. It was a really great moment. Vincent was here. And what we saw at this moment with the technique of Fernando was a real change in management of prostatic adenoma, and it's something that marks us for years. And that's the reason why we decide to move from vaporization, green light or thulium to the enucleation at the beginning of the 2010.
And so what was the aim of this travel and this experience? Of course, to improve the postoperative results, immediate postoperative results, and voiding results, and of course, reduce the risk of recurrence as we can have during vaporization or non-enucleation technique. But the problem that I had some constraints. I had to adapt my laser to the resectoscope, so I have to change my device. I have to be cost efficient, and as I told you, it was not possible at the beginning to buy or to purchase a morcellator. It was too expensive. And to keep the ability to perform vaporization and reduce the learning curve, because at the moment I was a beginner. So I had to take all these things in the pack and try to see the good way I can go to the objective to enucleation. But I also desires, for me it was probably an opportunity to develop innovation with industry and create a partnership with industries, which is always for a urologist something very interesting, I think, to discuss with engineers and go a little bit more in the industry business, and then try to move what the German guys was doing at this moment, which was TUVEP and vaporization with the thulium, to a real anatomic enucleation with the thulium. So for that, I decided to, with the engineers of Quanta System, we decided to switch the continuous wave mode of the thulium to go to pulse mode, to try to have the ability of dissection comparing with the ability of cutting, and try to have a Moses effect with a mechanical effect to try to open a little bit more the plan, because at the beginning the enucleation with the thulium was generally cutting like we do in vapoenucleation, close to the plan but not in the plan. And so that's the reason why we discuss with Rocamed and Quanta System to try to move the Cyber TM 200 watts laser to an evolution of the MRA system of Rocamed with the ability to change the settings and change the emission mode of the thulium, the typical thulium, the basic thulium, to another thing. And that's, I think, a very interesting project to cross my experience with the experience of the industry, and I recommend it to try to work with the industry and not against the industry. And so now there is a new evolution of this laser, because now it's a TFL, it's kind of rising up. We know it for the stones, but we try to find a good way to optimize the settings and the way to use it for BPH. So this thulium fiber was developed by Oliver Jackson for the stone with pump diode modules which activate a laser fiber and deliver a very impressive Moses effect with this system of thulium. It's almost a small wavelengths, honestly. It's the same characteristic on the tissue, but what is going different is the frequency of the pulse that you can have, and it's so useful for the stones. So as you can see, there is difference between, and it's at the worst part of the screen. With the TFL, you can rise up your frequency to 2020 hertz. And what is quite different with the holmium is that with the holmium, you have a great peak power, all right? And you deliver the energy in a very short time. And with the TFL, you can change the time of emission and to have more coagulating and hemostatic way to manage the laser. So you can change the pulse duration and the pulse profile when you adapt the setups of the thulium fiber laser. What is interesting is that it's not single use. You have single use for the stones, but you can use it with reusable fibers, and it's very interesting for the costs. So We have two thulium fiber laser on the market. One, sorry for the slide because I had a problem with the PowerPoint, but to be honest, there is one serious quanta Wakamet system and one source-safe system. The difference is probably the power. The Olympus is a 100 watt power, and it's a 60 watts for the quanta Wakamet system. But they are both very, very efficient. So for the enucleation technique, my initial surgical management was the 2 or 3 lobe technique. I think it's not a bad technique. Of course, you will have to move from this to apical release first and en bloc technique, but it was the beginning of my experience, and I have to copy that from the initial description of Peter Gilling. And now, of course, as Fernando showed you, we use an early apical release and an en bloc dissection. So I would like to show you, because tomorrow we're going to have a live with the 200 watt MOR laser. That's what we have. I would like to show you a short video about the serious technique and the TFL, because tomorrow you're going to see the intermittence, the pulse standard cyber thulium 200 watts. So it's quite a recent video. So what is very interesting with the fiber thulium is that you have plenty of settings. You can do what you want. You can do you can change the duration of the pulse, so small, medium, or long. You can change the frequency of the system, and of course you can see all the power. And I think that we're going to have to work on that. We're going to have to see what are the results of the different settings, because I think that they are very, very different in the way you manage these settings. You're going to have very different effects. So I try to use a long pulse, a low frequency, and almost at 33 watts. And as you see, I would like to have the same Moses effect. It's not the same, of course, because the peak power is lowest, but try to have a good Moses effect, because I think that with the time, what's going to be very important for the results will be try to not to touch the prostate. At the beginning of the experience, I had to dissect a lot with the resectoscope, and I think that when you do that, you're gonna probably pull on the different anatomic structures, especially on the sphincter, but on the capsule too. And I think that the less you touch the adenoma, the best you are for your result, because you're going to reduce the small damage of the capsule that can create, I think, irritative symptoms post-operatively. And of course, if you tract less your sphincter, we know that from radical prostatectomy, you're probably going to have better results for the continence after the surgery. So as you can see, I think that it's at the moment with the settings I have, it's a mixed technique between enucleation and blunt dissection and laser emission. So as you can see, you can find again the charring of the thulium laser, but we try to reduce it with the sphincter, with the settings, to try to see perfectly well the plan. So where the thulium is very interesting is the hemostasis. As you can see, it did almost nothing. What is more difficult for enucleation is the reduction of the Moses effect because of the duration of the pulse. What we know now from the guidelines is that What is very important is to do enucleation and anatomical enucleation. We know that, of course, we're gonna have slight difference between the different tools you're gonna have. I think that I have no experience with the very recent holmium lasers, but at the moment, for me, there is no absolutely perfect system on the market, because if we had one, we should probably have all the same. So we're gonna have some improvement with the thulium, I think, for hemostasis and perhaps irritative symptoms, but probably that the enucleation is a little bit more difficult because of, and so the during time of enucleation will be a little bit longer when I compare it to the holmium. So it's a mix, I think, between blunt enucleation and holmium technique with no touch. But as you can see, it works well. The settings will be very important to work on. As Fernando, I have to say that it's very important when you do your enucleation is to be very close to the adenoma. You have to detach the adenoma from the capsule and not the contrary. So you will see the effect between the MRA system and the Soltive or the Sirius system with TFL is not so different, for me, in my experience. When I use one, I use it almost the same that I was using the previous one. Perhaps I will quit this because it's a little bit long. So you can see the thermal effect. So new generation of thulium. So I will expose some results. So I don't want to be too long. So I just took this recent paper about meta-analysis comparing thulium laser and holmium laser for benign prostatic hyperplasia, and the results of the thulium are quite interesting, because you can see that operation time seems to be better with the thulium. Morcellation times is the same. Catheterization times is probably the same. Hemoglobin decrease will be in favor of the holmium system. But when you compare the results at 3 months, there is better EPSS and same quality of life. What I think, because of this EPSS, is probably that because it's a very superficial wavelengths delivered in the tissue, the cicatrization after thulium is quite good. And generally, when I see the patient at 6 weeks, they don't have any irritative symptoms anymore. So I think it's an interesting laser for that. And it's in the physical characteristic of the laser. It's not a big surprise. And when you see at 12 months the results, we have to say that it's probably comparable between the holmium laser and the thulium laser. So thulium is a safe and efficacious alternative to HOLEP and TURB. It's non-inferior, I think, and for some outcomes, but you know, papers, it's always the way you want to present it. But it seems to be better for EPSS at 3, 6, 12 months and 24 months. And thulium fiber laser have the advantage to be high frequency with less degradation and less energy consumption. So it makes for that quite cost effective and operational. So I won't talk about the guidelines because Professor Stavros did it perfectly. I just want to say that no problem with the thulium. It's recommended in all the case of prostate for vaporization, for vaporesection or enucleation in all that kind of patients. So it's like a swift knife of surgery for BPH and working with stones too. So I think it's quite cost effective and excellent tool to use. Thank you.
Dear Jean-Baptiste, thank you very much for this excellent presentation. I will start with one or two questions, and then I will address for people watching us and online users that are not asking a lot of questions. I have to see that. So we know, everybody knows that you are a world-class robotic surgeon, and you are doing also BPH. Do you find that doing BPH is boring? Do you prefer robotics, or it's how do you feel about that?
So you know what, that effectively robotic surgery is a passion for me, and I'm from a very important robotic team. But it was my business in the team to try to develop laser technique in Saint Augustin, and I have to say that it was a difficult way to go, but it's an amazing way to go, because when I began the surgery with vaporization, I think it was not a surgical technique, and that's one of the reasons I had to move to enucleation. And endoscopic enucleation is a real surgery. It's endoscopic and minimal surgery and minimal invasive surgery, but it's a real surgery. It's a real dissection, exposition of the plane, using tools, have a real, you need to really know the endoscopic anatomy. So it's absolutely not boring, and add all the very interesting technique like robotic technique. It's we have an evolution of the endoscopic enucleation all the time, and I think it's one of the reasons why it's a great technique, because like in robotics or laparoscopy, this surgical technique has an evolution, and for me, it's one of the proofs that it's a technique very interesting to develop, and probably a rock, you know, a rock in urology, especially for the treatment of BPH. And to be honest, I was doing at the beginning vaporization, then after enucleation for small prostate, and robotic surgery for big prostate, or laparoscopy for big prostate, because it was too long for me. And I have to say that now I've switched all my BPH activity to endoscopic enucleation technique. So I stopped probably robotic simple prostatectomy, because when you see the results for 250 grams of prostate and the patient is discharged the day after, and I think when you have a good anatomic experience, there is almost no incontinence after that kind of technique. I have to say that for me, for the recent years, it's absolutely no boring, because I convert all my BPH activity to laser enucleation.
Okay, and I see that you are using the Kunz element that we use normally for mechanical.
Yeah.
Do you think that the irritative symptoms are because of traction, or because of the amount of energy applied on the tissues?
I think both. I think that energy you deliver, especially with the laser or bipolar enucleation, irritative symptoms you create, because you're going to have an inflammation of the prostatic area after when you do the sacralization. But I think that when you do a blunt enucleation with the cystoscope, you're going to create some small damage of the capsule, and this small damage will have to cicatrize after, and probably create the irritative symptoms in the first 3 or 6 months. Because with time, there is no problem with the cicatrization. You have to know that to have an epithelialization of your prostatic area, you need between 3 or 6 months. So the less damage, traumatic damage you create, the less energetic damage you create, probably the less irritative symptom you're going to have. So if you improve your dissection, and if you manage well and more your laser, probably you're going to reduce the iterative symptoms you have after endoscopic enucleation.
Okay, thank you very much. Any questions, please?
Okay, so I would like to make a comment then. I know that this session is all about enucleation, and about the vaporization, there is a stigma that says that this is not a real operation, okay, and there is no place for that. I think that there is a place for vaporization, and I explain my thesis. And all this stigma is because of the aggressive marketing that had received the vaporization in the past years, and the bad results that came from that. But there is a specific subgroup. I have a couple of patients that I have operated with many years ago for urethral strictures, and they have urethroplasties. And some of them did not have the perfect urethroplasty because it was operated for me. So it's a bit, the caliber of the urethra is not the optimal. And I would be real grateful if I had a way to perform a BPH treatment with a smaller caliber endoscope. And the only way to do that is with vaporization. So it's not something that has no place. Sometimes it's the only way.
Yes, I have to say that the instruments now are going to smaller and smaller and smaller. There is a colleague from Argentina, if I'm not wrong, Fernando, that is doing a slim HOLEP or ultra slim, and Brazil. Yes, and it's 18.5 French of endoscope, so it's progressing.
The problem is not the endoscope. You can do resection with a small endoscope. The problem is the
Morcellation.
the morcellation, yes.
Yes, but
So you have to.
22 French.
Oh, I didn't know that.
Yeah, it's getting more and more visible.
please. The micro, please, for the online colleagues. Yes.
Okay, I'll give you. We should have a deep reflection on that because most of us, maybe human, have used to adapt the patient to our technique. So we have technique, we masterize, we learn a lot with the patients, and now we are extending one technique to many patients, to every patient. So maybe I think we should clarify that point on the sense that maybe a 90 years old patient doesn't need to be enucleated because it doesn't care about long-term results. Okay? So a patient with antithrombotic agents, verbal therapies like duodenum plus oral anticoagulants. Do we need to stop the oral antithrombotic agents just because we want to enucleate the patient? Maybe no, and there is a place, I agree with you, not only with anatomical consideration with the urethra, but the general health status of the patient. So we should not eliminate many options just because we are mastering perfectly enucleation.
And this is why I think we should master other techniques and minimally invasive techniques, either ourselves, like Resume or Urolift, or refer the patient to somebody doing that if we think that the patient needs another treatment, 90 years old or small prostate, or depends. So it's not we're doing enucleation and we're doing this to everybody, but we should adapt to our patient and his needs, of course.
This is the precision medicine.
Any more questions? Okay. Thank you very
Thank
much,
you so much.
Jean-Baptiste. Thank you. I would like to welcome also Dr. Meneghini that just arrived from Italy. Dr. Mizrahi is going to talk about the green light enucleation, a great friend of mine also from my residency in France. Thank you very much for coming and we're hearing you.
Thank you, and thank you for inviting me. It's always a pleasure to see friends, international colleagues, to share knowledge and sharing the cake. Just because when I listen to such speakers you invited, I always learn something new. It's a fact. So the attendees are not the only beneficiary from this kind of events. It's always a pleasure to listen international speakers and experts like you invited. So it's my pleasure to present you in front of the one who developed the technique, Fernando. So I'm always shy when I'm talking about green laser enucleation. So it's my pleasure to present you this technique, which is not a very new technique. It has been described years ago, but I will give you an overview. But I'd like to, we are on a meeting focused on the technique. So we are not only technicians, we are urologists and doctors and physicians. So don't forget the decision-making process. And I'd like to illustrate that point with poor decision perfectly executed, like we had the demonstration, and we will have also tomorrow. So poor decision perfectly executed result in poor outcomes. And I would like to illustrate that point with a patient who is coming to you in your office and complaining from nocturia. Qmax is 7 milliliters per second. So we think, okay, he has a BPH, BPO, Qmax is a testimony of that. So let's offer him an enucleation. Okay, so decision-making process is simple. And the patient is coming back 2 months later. Okay, great, I have a good stream, but I still wake up 5 times a night. Oh, really? Just because you forget to do avoiding agenda and you forget to clarify that the patient was urinating 1 liter, the amount of urine during the night was 1 liter. So the patient is still complaining from nocturia. So the decision-making process was not clearly exactly perfect. So be careful of that, be aware of that. So green laser, green light fiber. And what is the evidence with endoscopic treatment of BPO with the green light? So we see that green light is strongly supported with vaporization, but as Professor Gavras said, in the guidelines, in fact, enucleation with the green light is not part of the gentleman club because of the lack of strong evidence. We don't have RCT for that. We have 100, approximately, almost 100 papers in the literature, but retrospective or with low level of evidence. Retrospective study, even with a large number of patients, but the level of evidence is remaining low due to that. But there is a clear evidence that green light users are able to use the green light fiber to enucleate. Why? Because in fact, when you vaporize medium-sized to large-sized glands, you will have to face with a high level of BPH tissue recurrence. Not only with nodules, because when you enucleate, you can left nodules inside, but when you vaporize, you can leave a large amount of residual tissue that will regrow and give some hematuria, some lots recurrences, etc., years after, from 2 to 3 to 6 years, but recurrence as well. and you will have to retreat the patient surgically, because we all know that medical treatment is not useful in that kind of cases. So for the technique itself, let's focus now on the technique. For the technique itself, the cystoscope matters. In fact, it's quite impossible to do a blunt dissection when the lens of the optic is at the same level of the tip of the scope, just because when you slip on the tissue, you won't be able to see anything exception with a microscope. No, you have a clear and a wide vision when the lens is back, millimeters back from the tip of the scope, and that kind of cystoscope was designed by Wolf company. I don't have a disclosure with Wolf. I have to admit, I don't have. And the cystoscope, this cystoscope, the 24.5 shift, is able to provide the surgeon a wide view, even if you slip on the capsule, to dissect the adenoma. So to illustrate the surgery, nothing's better than a video. So this video, we've made this video with Benjamin Preneur, which is a French colleague, interesting and involved in the BPH surgery. So prostate volume 92 cc, 90, in fact, 90 cc. 73 years old patient, acute urinary retention after cardiac surgery. So settings, green light generator, of course, the Wolf instrument that allows blunt dissection, and green light fiber, which is not the most recent fiber, the Moxie fiber, but the oldest one, the HPS 120 watts fiber, just because the fiber is more robust, resilient, and we don't need as much energy to enucleate than for vaporization. It's 10-fold less energy than for vaporization, almost. So surgery starts as usual, looking inside, ureteral orifices, etc., etc. Nothing's less and nothing's more than the other surgery, endoscopic surgery with different energy sources. And the procedure starts, as Fernando described previously in the World Journal, and developed progressively more and more with the marking a white line, a groove, superficial groove to delimit the sphincter from the apex. And initially it was fear. Initially, for my first case, the cardio was at the maximum. In fact, when the cardio is very low, after many cases, you are more at risk to do some mistakes during the surgery, so be careful of that. So the cardio, when the cardio is at is maximum, you don't want to see the sphincter because the sphincter has to be behind you. The less you see the sphincter, I thought, okay, the best it will be, but it's completely wrong. You have to see the sphincter to clearly delimit the apex of the prostate from the sphincter, and you can avoid like that issues, trauma. So superficial white line, coagulation mode. So the settings are 40 watts for coagulation and 80 watts for vaporization. So small, limited energy delivery. So it's very important to spend some time to mark the sphincter, mark the apex. So really apical release, like all the speakers before me told you. And you see the movements of the scope on the right side of the screen are really smooth. So I will accelerate the video a little bit. Cystoscope position. So now is the time to release the adenoma from the capsule. So gently press, gently move laterally at the apex to detach the adenoma. Sometimes the adenoma is detaching really easily. Sometimes not, and we can use the tip of the fiber, like a small finger, small tool, to find the right plane, not to go deeper, not to be too superficial inside the adenoma, because the procedure will be much more difficult inside the adenoma, of course. And I like to emphasize the importance of releasing the apex as much as possible without leaving this kind of nodules, because it will be much more difficult to follow the curve of the adenoma after, if the apex is not released completely, if there is some remnant tissues. So I use vaporization to cut, the cystoscope to detach, and I often move the cystoscope back to see where is the sphincter. I know where is my sphincter, but the patient, of course. And I do gently. Endourologists are the most gentle people all over the world. It's a quote of, I don't know, I don't remember, maybe Olivier Traxat, I don't remember. So gently detaching the apex, and I do the hemostasis step by step. At the very first time, I left the hemostasis for later. Okay, it's nonsense, because later will be too late. In fact, it's much more difficult to do the hemostasis at the end than when you do it when you carry on the hemostasis step by step. Even if the space is allowing a good vision, don't let the hemostasis for later. Do it step by step, frequently. So yeah, we have many ways to do the hemostasis with the coag mode, of course, the pulse mode. So 40 watts delivered on the tissue, on the vessels. And you have a nice one for larger vessels. So of course, it's not the aortic tube, but even some small vessels, arterial vessels, can impair the vision. And it's very difficult, because if you vaporize the tissue, the vessels will go through out of the capsule, and then you have to search from the vessel to coagulate properly. But you can use the extremity, the tip of the fiber, which is not cooled, as with the most recent fiber, the MOXIE fiber is cooled to improve the durability of the fiber, the life of the fiber. But this fiber is not cooled, so you can use the heat of the fiber. Here, precisely, there are sometimes you can face different planes, so there's discrepancies between planes, and you have to choose, okay, which plane I should go through. This one or this one, maybe this one, okay, but you see that it's not the right plane, because the tissue is not like it used to be, and if you go deeper, you will face the thin capsule, maybe the fat. So my deposit, okay, I should go back, and find the right plane. Typically, this prostate is fibrotic, much more difficult, even if it's only subjective. We didn't find any difference between patients taking Combodart or other alpha reductase inhibitors for many times compared to those without. We didn't find any difference in terms of capsular perforations or operating time. But okay, with a limited number of patients, so maybe conclusions could be different with a large number of, with a much more large cohort. And then we see the right plane. And I detach progressively. I use the vapor. Typically, the amount of energy at the end of the procedure is 50 kilojoules, 60 kilojoules for a prostate of 80 grams. Compare vaporization 10-fold more, at least, and much more longer when you vaporize such a large prostate. So, like Karin Lerich said, you dance around the adenoma. I think I found this quote really beautiful. You dance around the adenoma, so you follow the curve. In fact, it's not a cube. Yeah, the prostate is not a cube. It's a sphere. It's a sphere. So don't forget that. We have to be aware about that, especially at the beginning of the learning curve. Prostate is not a cube, yeah, of course. Okay, and now I detach the adenoma completely. I mobilize the prostate at the level of the bladder neck. Okay, I move forward the video. So we see that the adenoma is almost detached from the capsule. I used to detach the upper part at the very beginning of the procedure and not the base of the prostate. Because if I release I found that if you release the prostate at 6 o'clock first, it's very difficult to reach the upper part, and you have to tilt the scope, and then maybe the sphincter is at risk to be stretched because the adenoma will lift up. If you detach at 6 o'clock position first, the adenoma will lift a little bit, and then the scope, you need to lift the scope to detach the upper part. So I used to detach the upper part first, and then after the lower part of the prostate. And carrying the hemostasis progressively to make sure that there is no bleeding before moving to the morcellation. Coagulation of the fossa. I will vaporize some small tissues, some remnant tissue at the apex. To clean the apex, in fact, cleaning the apex. To avoid the anterior flap. I check again ureteral orifices and then proceed to the morcellation. So now at this point, when you start the procedure, the cardio is low. Your cardio is low because, okay, you think you've done the most important part of the procedure, and then, okay, I'm fine. No complications so far. Everything is okay. Patient is sleeping. No bleeding. The adenoma has been detached. Okay, it's in the bladder. You flip the adenoma in the bladder, and then everything should be okay. I left a little bit the level of my attention, but no, you should not, because there is a second part more as crucial as the first, and as the speaker said before me, it's the morcellation is crucial to train the team, to make sure that the irrigation is on, etc., etc. And I used to put a catheter without irrigation most of the time. Sometimes yes, of course, but most of the time no irrigation, and remove the catheter the day after. So the learning curve, as it has been said previously, that the learning curve is extremely widely reported in the literature, from 30 cases to 200 cases. So initially, we report with Grégoire Robert in Bordeaux and Benoît Perronnet and Jean-Nicolas Cornu as well, the first study, 100 patients operated with green light enucleation, and 100 compared to 100 patients that who underwent OLEP. And we found that, okay, 30 cases is enough to overcome the learning curve. And then we combined some different settings in the methodology. In fact, it depends on what you put in the bucket. If you want to analyze more precisely the learning curve, you will find some many different, very different results. And we published a wider, bigger study with a large number of patients. And we found that, okay, 30 is not enough. Maybe 200 to master the complication. And I used to say, you're only good when you can solve your own complication, and you are unable to solve your own complication after 30 cases. Okay, you know the basics, principle, things to avoid, to do. Okay, but everything, no, you don't know. And the second thing is that you have to know your own results. If you are in front of the patient, don't tell the patient, okay, you have 2.5% of risk of incontinence. No, this is published in the literature by, I don't know what kind of experts. Okay, your results. So even if you don't publish your results, because it's more and more difficult to publish retrospective studies, I know that. But it depends on you to ask someone else, a clinical researcher or a resident, or I don't know. If you evaluate yourself, from a human perspective, it's difficult because we don't want to be evaluated by ourselves. It's very difficult. We don't like that. So ask someone else. Okay, collect my data and with the first 30 patients, and give me a feedback on my results. Okay, how many stress incontinence? And that's why when I published my first results on GreenLab, I published the paper on Journal of Urology. I don't know why they published this paper, because the rate of incontinence after GreenLab compared to PVP for the same range of prostate size was 25%. Ooh. So everyone took this paper to kill the technique, and they wasn't aware, nobody wasn't aware. I was aware that I was in the mild learning curve. Okay, I was in the mild learning curve, and the technique was not described as it is now, thanks to Fernando and the colleagues. The amazing work he did to describe the technique and to standardize the technique. But okay, I was in my learning curve, but and they didn't take in consideration that the patient, the incontinence resolved. Okay, it resolved. Okay, at 6 months, only 1.5% or 1% of patients still complaining of light stress incontinence. Okay, so it was not a drama. Okay, it's 6 months, 2 months, 3 months, 6 months, difficult for the patients to experience stress incontinence, but it was not a huge drama, and I did not put a sphincter, and I follow up all my patients in database with my clinical researcher. I'm not doing that myself, and I'm not doing my statistic myself. But it's really important at your level when you start something, a new technique, to evaluate yourself, to be able to what kind of things I should improve. Maybe I do wrong. Maybe I should ask Fernando again to go back, or Jean-Baptiste come back again to train me. Okay, because I missed something, because my results are not really good compared to what you said, and it's very important. I would like to emphasize that point. You notice that. So the perioperative outcomes. What are the perioperative outcomes? In fact, the literature is scarce, and we have only limited data, robust data. But I choose to show you a large study involving 1,000 of patients, and we compared PVP and green laser enucleation, and we see that, in fact, the energy, the amount of the energy is very limited compared to PVP. The capsular perforation, okay, well, the capsular perforation was interestingly lower than for PVP. Even if you do blunt dissection, capsular perforation was really limited compared to PVP, because PVP you can arm the capsule with the laser if you don't pay attention, if you vaporize too deep. Bladder injury, it's due to the morcellator. And major complications were a little bit higher, significantly superior compared to PVP, just because it's a blunt dissection. Even if you coagulate very, very well with this wavelength, it's a blunt dissection compared to vaporization. You have more coagulation efficacy with the vaporization than for enucleation. The length of stay was similar between the two. In fact, I have to tell you that it was from the first patient to the last. It was a multicentric study with many surgeons, and it was their preliminary experience. So from the first to the 200th patient, so it included the learning curve. So that's why it can explain the non-significance of between maybe the length of stay, for instance. After months of follow-up, we can see that the Qmax, which is the most important thing, even if the Qmax is prone to variability of measurement, when you jump on the weight in the bathroom, okay, if you change the position of the foot, the weight will be different. It's the same when you measure something in urology. If you measure the Qmax, maybe the second measure will be less or maybe much more. So there is a variability. But accounting on that, even if we account on that, GreenLab was much more proficient in terms of Qmax than with compared to vaporization. So the green light fiber can be used, of course, for enucleation, but is still considered, because of the lack of data in the literature, is still considered as an outsider. But in a general perspective, green light laser is a much more versatile laser, because with a single wavelength, you can treat many clinical cases. You can do PVP, of course, for frail patients, and all patient antithrombotic agents without modification of the antithrombotic agents. You can do PVP without interrupting antithrombotic agents. I'm not sure that the literature is supporting with a high level of evidence that enucleation is safe when you don't stop oral antithrombotic agents. I'm not sure of that. Maybe retrospective, but prospective study, I'm not sure. So you can use the green light laser to do PVP, of course. And if you are afraid not to be complete when you treat adenoma with PVP, of course, for small to medium-sized gland, you can use vapor enucleation. So you will detach in a progressive way to learn. And Dr. Roche was talking about that with the thulium. In fact, you can use the laser not to follow exactly the plane. In fact, with the green light, when you do vapor enucleation, you can follow the plane of enucleation, but you will vaporize, you dissect the plant, the adenoma, and then you will vaporize what you detach from the capsule. Just vaporize. Don't use moisturizer, but it's a progressive approach to the enucleation, the complete en bloc enucleation technique. That being said, thank you very much again for your invitation.
Thank you very much, Vincent, for this excellent presentation. I wasn't sure about how we were doing with green light, this kind of enucleation. It seems that you are controlling yourself, your results, and you are publishing, and I will be a little bit provocative. They are not, you are rare, you are just doing a green lab. Do you think that you are on the right side of the history or not?
I'm doing, we have the thulium, Subtil, in our department, and I do some TULIP as well. So I'm not focused exclusively on the green light, but I from a physical perspective, I found some interesting papers in the literature, but really difficult to understand because I don't have the background, scientific background to understand everything on that. But some papers dealing with the wavelength of the laser and the modification of the epithelium of the vessels according to the wavelengths. So sometimes some wavelengths will activate some cascade of, I don't know, and green light and the blue light is supposed to deliver the best hemostasis in terms of histology, from an histological perspective in these kind of papers. And some lasers are activating as well the hemostatic cascade, which I wasn't aware of. But it is really difficult to understand again these kind of papers. But I'm not focused on a single wavelength, so I use many things. But honestly, I had the thing that okay, green light is doing good for hemostasis, and we are conducting a randomized controlled study, national randomized controlled study, with the green light vaporization exclusively with patients under oral antithrombotic agents, oral anticoagulants, which are antithrombotic, but oral anticoagulants, Eliquis, etc., etc. So the patients are randomized in 2 arms. Of course, patients required BPO surgical procedure, and patient will be randomized in 2 arms. So you stop, and after the surgery, you bridge with low molecular heparin few days, and then restart oral anticoagulants. And the other arm, you don't stop. So at the time of the surgery, the patient is still under oral anticoagulants. We approach the study completion. So study completion, 386 patients. So it will be maybe done at the end of the year, or maybe early 2023 for the results. But my thing is that there is no difference. So we could change with this paper the guidelines from the anesthesiological point of view and our point of view as well, that it's safe to vaporize patients without bridging with a high level of evidence this time. So that's why I'm mostly involved for green light, but
It's not exclusive.
No.
Okay.
No.
I would like to thank Dr. Makarounis for his comments, and have a question from the audience that we should ask. There are some irritative symptoms with green light. We know that. It's from Dr. Patras. Do you think that with the green lab there are less than with evaporation?
I don't like to say I think, because I think it's used to be low level of evidence. So I don't know. Anyway, my position on that is, okay, the patient will complain from irritative symptoms for a few weeks. I give patients non-steroid anti-inflammatory, if it's possible, of course, because if a patient is under oral antithrombotic agents, it's really difficult to introduce non-steroid anti-inflammatory. But if irritative symptoms do not disappear with non-steroid anti-inflammatory. It means that there is something wrong, maybe a tissue, a fluffy tissue, necrotic, fibrotic, or a retral stricture. So it's not a big deal to, the patient can afford some irritative symptoms, not refractory to non-steroid anti-inflammatory, but they can afford that for a few weeks. It's not a big deal, honestly. It's not a major complaint from the patient. Of course, if it is prolonged over 2-3 months, okay, it's difficult. And we have to search why there is such a condition. But I didn't see any difference between the energy sources.
Okay, thank you. There are no other questions. What do I see here? So, allow me one comment for the organizing committee. Mr. Gravas, Professor Gravas, would say that show me your results. There is an argument that, in my experience, there was a session from European urology, I think, that it was the most crowded session I ever seen in my life. It was in a room, 2,500 people. And the title of the session was How I Do It. So we're urologists, we care about the data, but we also care to learn about the individual experience. If that makes any sense, Professor Gravas.
I think I have to reply. So you are right and wrong. I mean, there are always some pioneers, like Fernando, like Jean-Baptiste or Bisson, that they are committed to test all the new treatment modalities. And when they prove that they are good, then you are going there to learn the method. So that's why. So when we have this How I Did session, we have all the data behind it to support this session. So it's not only, actually, this is the beauty of urology. We have all these toys for boys. So it's when we have something new, we want to take it and to adopt it in our practice. But we cannot afford to adopt everything, not only from an economic perspective, but also for our patients. Because if something is not good, it's not good for our practice, not good for our patients. So if we have the data, yes, then we are moving to this How I Do It session, like this educational course today, because mostly for all the methods we analyzed are established methods. So they have data to support it.
Thank you for your answer.
I would like to add, we used to remember our success, but not our failures. So it's important to review our own results.
Any more questions? Yes, Dr. Roche, please.
I think that there is, when I see all these guys, and I remember the first hours I was in the operating room about enucleation, and I remember how difficult it was. I want to make a comment. I think that what is very important to do enucleation is to have your knowledge in the papers, in the video, and try to have the good devices to use. Depends not actually on what laser you're going to use, but you need to have a good oscillator, a good resector. You need to spend time on video, you need to spend time with proctors, and you need to be very careful about this technique. It's not a technique that you're going to learn after 3 radical prostatectomy in the day. It's sometimes you need to take some time to do it and to perform it properly, because it's an amazing technique with amazing results. But if you do wrong, your patient is going to be really wrong. And don't forget that it's functional surgery and not logic surgery. So the patient needs to have a perfect functional result. So please try to keep on mind that is difficult. It's not only BPH technique and so a secondary line technique. No, it's a real surgical technique with a strong learning curve, and you need to have all the force around you to go to your goal. So I think that try to be careful on that.
Κάτι τόπους να δείξουμε στην οθόνη να σας δείξω. Κάτι που σου γράψω αυτό δεν μπορεί. So I would like to invite our next speaker. My friend Petros Odoulidis, please proceed.
Dear Andreas, Thanasis, thank you very much for this very honoring invitation. It is a pleasure and a privilege to be among such distinguished faculty and masters of enucleation, actually. I don't consider myself a master of enucleation. I just started doing bipolyp a couple of years ago. And I'm going to, after those fantastic lectures on lasers in enucleation, I'm going to try to convince you that this procedure can be done without using lasers. So we are actually doing the same thing.